Good morning, everyone. Thank you for joining me today. I'm speaking today from the unceded traditional lands of the Musqueam, Squamish, and Tsleil-Waututh Nations, here representing from BC Children's Hospital. My talk today will really discuss around the social significance and physiological roles of androgens. I think our familiarity with androgen deprivation is really in the setting of disease states and involving the HPG axis. However, there's still a very broad social and identity phenomenon that has evolved in how we view androgens and the people with and without them, specifically in how androgens have shaped different roles in history going back thousands of years, as well as the history of urology to present day. So I just want to start with thanking and acknowledging the help that I've received on this talk from Dr. Alex Cavanaugh and Dr. Saint Laurent. The overview of my presentation will guide us through the physiological roles that androgens play and how they are regulated, helping us to better understand the roles of targeted therapies as well as for androgen deprivation. This is likely the area of more familiar knowledge. And then I'll bring us to maybe an area of less familiar knowledge in the discussion and the roles of androgens that have shaped history, specifically with ancient eunuchs and the introduction of modern day eunuchs. This will bring us to the history of urology and understanding how androgen deprivation strategies in other disease states, including BPH and prostate cancer, were developed, as well as guidelines that support our management of patients on androgen deprivation therapy. Throughout this talk, I'll also touch on the social phenomenon we see and how androgens shape gender, sexuality, and identity in a larger context for cisgender and gender diverse individuals. The objectives are tailored to a lot of the different folks that are listening in today, whether you're a medical student, a urology trainee, or for those who are in practice. The role of testosterone and other androgens hosts a myriad of functions in the body, whether derived endogenously or provided exogenously. We often see a loss or decrease of these functions with a loss of circulating androgens. Mainly in the brain, libido, mood, and executive function and memory are controlled, and they often affect the quality of life. In the muscles, we see the development of lean muscle mass, as well as in bones, the development and maintenance of bone mineral density through the action of sex steroid hormones on osteoblasts and osteoclasts. In the bone marrow, testosterone induces and increases erythroid colony formation and the red blood cell production. In the gonads, testosterone works locally for virilization, and we often see this through either endogenous or exogenous sources, familiar in the pediatric population causing virilization, as well as we see the action on spermatogenesis, prostate growth, and erectile function. In the skin, we see body hair growth, as well as the activity of collagen for wound strength and healing. What's not included in the schematic is the cardioprotective effects of steroids on coronary disease and the development of metabolic syndrome. The physiology of androgen production is mediated endogenously by the hypothalamic pituitary gonadal axis. The release of GnRH from the hypothalamus stimulates the release of peptides LH and FSH from the anterior pituitary, and they go into circulation. The action of these peptides mainly work on the Leydig cells in the testes, mainly by LH, or on theca cells in the ovaries to stimulate the production of testosterone and androstenedione, respectively. The action of ACTH from the anterior pituitary also stimulates the production of androgens from the adrenal gland's zona reticularis. However, only less than 5% of circulating androgens are derived from the adrenal gland. Whereas 90 to 95% of circulating testosterone reaches the target organ and exerts its effects through the nuclear androgen receptor, a small fraction is peripherally converted to DHT via 5-alpha reductase in the prostate and skin. Aromatase in the bones, fat, and brain convert testosterone to estradiol to act through the nuclear estrogen receptor. Similarly, we see the action of aromatase in cis females in the ovarian granulosa cells. The androgen receptor itself is a transcribed gene from the X chromosome. This means that XY individuals have one copy of this gene, whereas XX individuals have two. The translated protein arranges to become a 919 amino acid and 110 kilodalton protein, consisting of 3 functional domains, noted in the abbreviations here on the left. the N-terminal domain, the DNA binding domain, as well as a ligand binding domain separated by a hinge region. The ligand binding domain and pocket can be seen in the 3 structure on the right, and the moieties that form a protein ligand interaction for its activity. Testosterone, DHT, and R1881, which is a synthetic potent androgen, all have varying affinity for the ligand binding domain of the androgen receptor. The conformational change that the protein undergoes with the ligand binding allows for dimerization and DNA interaction of that DNA binding domain to nuclear sequences that allow for transcription factor effects that mediate the downstream role of androgens. However, the androgen receptor activity can also be achieved in the absence of androgens, as we see sometimes in disease states. We often come across states of androgen deficiency in the setting of either congenital mutations or idiopathic causes of decreased androgen production, a loss of androgen activity, or its sensitivity. This can be either hypophysial or hypogonadal, or sometimes via somatic mutations usually identified in our pediatric populations. On the other hand, acquired androgen deficiencies are more common in our adult population, either in the setting of our androgen deprivation therapies that we're familiar with, so such as LHRH agonists and antagonists, the use of antiandrogens, or through surgical castration. For gender-affirming hormone therapies, estradiol and spironolactone are often used in North America versus cyproterone acetate in the European population for combined androgen blockade prior to gender-affirming orchiectomy. Irradiation to the gonads or pituitary can also result in decreased androgen production due to either primary or secondary hypogonadism, respectively. These discoveries over the more recent timeline, so more to our right side, have helped us to more scientifically understand the action of androgens, as well as the androgen receptor, beginning back in the 1930s. Going back in history, we have gained a lot of understanding and knowledge about the role of gonads and testosterone formation. In the 1950s, this was the first time a gender-affirming surgery was performed. In 1894 was the first human vasectomy reported. And in the before Common Era, in the early centuries, eunuchs were documented in the Roman, Ottoman, and Chinese dynasties, as well as within biblical stories. The first person to be ever castrated was thought to be about 4,000 years before the Common Era in Uruk, Mesopotamia. And even further history about the role of castration in the domestication of large animals. So I really want to focus this history of castration mainly on that population of ancient eunuchs, as well as what we've come to know about the action of androgens prior to the studies and reports that we have today. So the term eunuch is actually an English translation of 2 Greek words that mean the guardian of the bedchamber or a chamberlain. This is because historically, eunuchs served trusted roles as diplomats, as senior military officers, and within governmental roles in various empires, including the Ottoman, the Chinese dynasties, and the Mughal Empire in India. And these eunuchs were often tasked with overseeing the imperial harem as the chamberlain without fear for deviance, as well as supervising the education of the imperial heirs, overseeing palace staff, and attendance to higher ranking individuals. The reasons they were seen as trustworthy, pure, and loyal was because of the notion that eunuchs embodied a third gender, neither male nor female, something that we would probably refer to as gender diverse today. The images on the right about young and old eunuchs illustrate the vast number of these individuals. Each emperor maintained 2,000 eunuchs. The prince and princess each had 30 of their own, and other family members possibly had 10. So many families in poverty would sell their children or have them undergo castration to gain employment. The way that castration was documented in our eunuch population came in sort of 3 forms, either as full nullification, so the removal of the penis, the testes, and scrotum, only a bilateral orchiectomy, or the crushing or bruising of testes. The earliest documentation and translation of this procedure dates to a Chinese physician in the early Common Era, where a patient would be restrained. Surgical prep in the form of hot brewed pepper pods would be used, followed by a swift stroke of a sickled blade, as seen on the right bottom side there, to remove the appendages in one go. A pewter plug would be placed into the urethra to prevent stenosis. And these patients were not allowed to eat or drink for 3 days, similar to our cystectomy patients. And after that, the pewter plug would be removed and allowing them to void. And if they were able to successfully void, the procedure was considered a success, but there was still a 2% chance that these cases were fatal, likely due to urethral stenosis and infection. The wounds typically healed within 100 days and can be seen in the image of the young eunuch on the right depicted as well. Throughout the centuries, eunuchs were found to play many important roles. In the 17th and 18th century, castrati singers were praised for young boys that had high singing voices that would be preserved through castration. These castrati singers are popular in opera and choruses in Europe, specifically for the Pope in the Sistine Chapel choir. These pre-pubertal eunuchs would not develop facial hair and would not go any development of significant pubertal development, but they would develop osteoporosis and thoracic kyphosis as older men. The depiction of eunuchs is also present throughout biblical narratives, where priests and religious cults were often perform self-castration as a way of gaining the eunuch calm and being closer to God. These themes of castration are often depicted within Renaissance artwork and through mythology. Here's an example of Cronus, or Saturn, who's castrating his father, Uranus, in this oil painting. Today, the investigation and study of modern eunuchs and their population has largely been through online surveys of individuals through a forum called Eunuch Archives. Modern day eunuchs are very much a marginalized subculture through their online community, as well as they host meetups in North American cities as well. And these are individuals that have either gone nullification or emasculination through bilateral orchiectomy, with or without penectomy and scrotectomy. Chemical eunuchs often are individuals that have undergone androgen deprivation therapy with the use of LHRH agonists or antagonists. And finally, the majority of individuals on these forums are eunuch wannabes, or people who are interested in exploring their desire to undergo castration. Through the research that's available, there are trends that are reported for the common motivation and desires for individuals who are wanting to undergo castration or to become eunuch. These often include things like growing up on a farm or witnessing the castration of farm animals, a history of sexual or emotional abuse with a threat of castration as punishment, individuals with a dysmorphic view of their genitals, or individuals with castration paraphilias. It also includes those who have been raised in a very Christian or religious household, and individuals needing to possibly please their partner, either to decrease their own libido or in a sadomasochistic and submission domination sort of fantasy. That's to say, the eunuch population is a very heterogeneous and a group, and should not be considered as those only with psychiatric differences. So I want to touch also on the Hijra population in India. When I was 8 years old, I traveled to India with my family for the first time. At a wedding reception there was a group of Hijra women that had showed up and began to sing very loudly and dance. They were asked to leave by the organizers of the wedding and the parents, and they became very angry and started shouting at the group until someone basically gave them money to go away. I remember asking my mom about what was going on, and she said that these people would come uninvited and would threaten to put either an evil eye or a curse on the newlywed couple if they weren't given money for their blessing. The term Hijra itself is an English translation of the word eunuch. Having more information about the lived experience of these people and sort of coming to know more, many Hijras don't actually identify either as male or female. It's more of a non-binary or third gender. and some of these individuals do identify as trans women as well. They're often individuals who are assigned male at birth or have differences in sexual development. The Hijra population also undergo a castration ceremony whereby their male or external genitalia are removed in offering to a Hindu goddess, Bahuchara Mata, who's the goddess of chastity and fertility. The existence of trans and non-binary people and their role in Hindu culture has been present for millennia, with the ostracization and the criminalization of this gender minority during the early British rule. While the Indian Supreme Court only recently legalized the existence of people with this third gender identity, they still face a lot of discrimination, marginalization, and violence due to the poverty and generations of colonization. For individuals who are seeking castration, and this is typically presented in the research as well, is there's a few paths to undergoing castration that are all painful and not very effective. These are seen sometimes in our own emergency departments or on call at St. Paul's. The first one here is a Burdizzo clamp. It's seen on the right. It's used to actually crush the spermatic cord of beef cattle. Alternately, the elastrator is a device that places a tight rubber ring around the scrotum and testes, allowing for a slow necrosis. Finally, individuals may result to performing their own repeated intratesticular injections of either substances like ethyl alcohol, lactic acid, zinc gluconate, or calcium chloride to cause necrosis, eventually being seen by a urologist for surgical intervention. For individuals that are not able to access healthcare, sometimes they may go to underground cutters. These are individuals that are looking for surgical castration. The sequelae of castration in this population are somewhat well understood from other disease states, with early decreased levels of circulating testosterone, resulting in loss of libido, fatigue, hot flushes, or vasomotor symptoms. And then the longer term symptoms or changes that we're seeing are usually gynecomastia, bone demineralization, penile shrinkage, anemia, metabolic syndrome, and muscle wasting and mood changes. In 2022, the new Standards of Care 8 by the World Professional Association for Transgender Health, or WPATH, included a new chapter on eunuchs. So these are individuals that are assigned male at birth with either gender incongruence or desires to eliminate their masculine features, such as their male genitals or their genital functioning. These are individuals that would normally fall under the gender diverse umbrella, and they must self-identify as eunuchs. As such, there's often great difficulty in finding gender-affirming surgical providers, and they often rely on self-castration, self-injury, or underground cutters as described. For individuals unable to access care for surgical castration or chemical castration, these are often people that end up in the margins. For those that do make it to a provider, topics such as fertility preservation should be discussed prior to medical interventions that impact future parenthood. And these are recommendations that were provided by the Association. So part of the standards of care also mentions that individuals that are castrated for medical indications may not identify as eunuch, and as such are not considered eunuchs. In urology, there's a rich history of surgical castration for androgen deprivation, specifically in the management of disease states. These individuals often share a lot of commonality with eunuchs in that many do not undergo hormone replacement and experience similar sequelae of androgen deprivation. The history of surgical castration in urology begins in the late 1890s, in Philadelphia, actually, with J. William White, who applied the use of bilateral orchiectomy for patients with urinary obstruction, likely secondary to BPH. Later on, the seminal work by Dr. Charles Huggins and Clarence Hodge were the first to demonstrate the effect of bilateral orchiectomy as well as oral estrogens for the favorable treatment of hormone-sensitive prostate adenocarcinoma, eventually leading to the Nobel Prize in Medicine in 1966. They found that comparing men with advanced prostate cancer, those with BPH, and as well as healthy men, and their response to orchiectomy or oral estrogens, they saw a response in the serum acid phosphatases that were being used as markers at that point for that were reflective of the therapies, either through medical or surgical castration, with also improvement of clinical symptoms. With chemical castration, there's also a history that we're aware of in terms of the use of LHRH agonists and antagonists today. And this comes from a Canadian legacy moment of Dr. Andrew Sahil. He was a Polish endocrinologist that moved to Montreal to do his PhD in the early 1950s. His work was first to isolate the GnRH and as well as synthesize small peptide inhibitors of GnRH. Notably, this was done in collaboration with Dr. George Tolles at McGill, and they conducted the first clinical trials of GnRH for patients with advanced prostate cancer in 1982. Here are their seminal papers characterizing these findings and success with chemical castration to prevent both the ovulation of women, for the suppression of testosterone in trans women, as well as the progression of to prevent the progression of hormone-sensitive prostate adenocarcinoma. So eventually this led to early studies to compare the outcomes of both surgical versus chemical castration in advanced prostate adenocarcinoma. This was reported here in The Lancet in 1985. Both surgical orchiectomy and LHRH agonist microcapsules showed efficacy for castration and both clinical improvement in symptoms in their randomized trial setting with only 41 patients. Furthermore, we've really come to know that the timing of testosterone castration is effective for surgical orchiectomy, and it usually occurs within hours. This early study looked at the serum levels of testosterone in castrated men, and they reported the time to be within 3 to 12 hours. And they also compared this to oral estradiol therapy for chemical castration, where the levels of testosterone were able to reach castration more within a weeks to months range. We also know that surgical orchiectomy is a very fast procedure. The main risks include bleeding, infection, and just undergoing anesthesia for the procedure, but it's quite a cost-effective treatment nonetheless. So now that we have these newer developments of chemical castration strategies, the trend for surgical orchiectomy has changed over the last decades, from the 1990s to the early 2000s to now. In a recent publication by Weiner and colleagues, they used a large US-based cancer registry of over 24,000 patients, and they used to analyze these results to assess what the trends of surgical and chemical castration have been over these last few decades. What they reported was the use of surgical castration actually decreased from 8.5% in 2004 to about 3.5% in 2016. The men who were more likely to undergo orchiectomy were those with limited healthcare access, either with insurance in the United States, or who were systemically marginalized, either by race, by lower income, by lower education, or by geography. Individuals in community hospitals were more likely to get surgical orchiectomy than those in academic centers. Speaking to our own urology staff, there are often times that where marginalized individuals in our own community with limited healthcare interaction or follow-up are often better served with surgical castration. Of note, the study also reported that there was no real difference in survival benefit between castration strategies that really drove this change in practice over the last few decades. So despite similar differences in overall survival and quality of life metrics and better cost effectiveness, surgical castration still tends to lag behind the current use of chemical castration, specifically with LHRH agonists and antagonists. So should we be doing more to offer surgical castration for ADT? Identifying those who might benefit or who would find difficulty with follow-up or compliance for injections or medications, as well as those with a need for continual interaction with medical healthcare personnel. Individuals that undergo surgical castration can also be those that are individuals with persistent elevated testosterone despite complete androgen blockade. Although we know that orchiectomy is not reversible as a form of androgen deprivation therapy, it doesn't really provide the option for intermittent ADT, which we'll cover a little bit later. But there tend to be a lot of bothersome side effects, including gynecomastia, as well as the loss of circulating androgens. There could be other strategies, however, for the symptomatic management that we can offer patients. So what about the cardiovascular complications? And androgen deprivation therapy often is reported alongside with cardiovascular health risks and reported adverse outcomes for specific things such as acute MI or stroke. While there haven't been large-scale multi-center randomized controlled trials that really compare current LHRH therapies to surgical castration with respect to cardiac complications, the data that we use to sort of compare this comes from retrospective analyses. There are usually smaller cohorts that are in these larger cancer registries that are orchiectomized, and so they provide somewhat of a context. So one of these papers was by Kan and al. In 2022 from a Taiwan cancer registry, and they reported that the overall risk of major adverse cardiac or cerebrovascular events in a short follow-up period was not significantly different between the patients that underwent surgical or chemical castration, though they were likely underpowered for being able to assess these given the low incidence of MIs. And things that were not able to be controlled as covariates included BMI and smoking status. Another study in 2016 by Sun et al. Was another retrospective analysis looking at US-based trends. And so these are 3,300 men in the US that were either had undergone surgical or chemical castration. And what they reported was there was an association for those with surgical castration with lower rates of fractures, peripheral arterial disease, and cardiac events in the 13% of those people who underwent surgical castration compared to the majority, the 87% that underwent chemical castration. So overall, similar concerns can also be raised for the generalizability of these outcomes given the populations. So I want to shift gears a little bit to discuss the alternative forms of androgen deprivation therapy that are available to individuals. The first being estradiol therapy. So this was obviously shown in those early studies of ADT by Huggins and Hodge, and often routinely used in gender-affirming hormone therapy to downregulate testosterone production in the HPG axis. Estradiol therapy was initially given through either oral or parenteral routes. In earlier studies that compared oral therapy to LHRH agonists, the side effects of estradiol were much higher, including breast events, GI symptoms, edema, as well as a higher trend that was non-significant but for thromboembolic events, which are felt to outweigh the benefits of the decreased vasomotor symptoms than bone health. The data over the years led to a shift away from oral estrogens to more of the available LHRH agonists with a safer side effect profile. However, more research, better research, and understanding of estradiol therapy has helped to develop the standard use of transdermal estradiol, whereas the previous oral and parenteral estradiols would undergo a hepatic first pass mechanism, where more prothrombotic proteins would be synthesized. There would be instead avoidance of this pathway through the use of transdermal estradiols. This would avoid the cardiovascular toxicity as well as the thromboembolic events that were felt to not warrant androgen deprivation with estradiol. As well as providing some of that sex hormone back can be protective for cardiovascular health, for bone health, for mood, as well as libido in select patients. Likewise, the development of breast events and weight distribution can be somewhat distressing or even dysphoric for some individuals. Recently at ESMO in 2024, there were results of the PATCH study that were presented by the senior author, Ruth Langley. So this was an open label randomized phase 3 trial, which was aimed to determine non-inferiority of LHRH agonists in the setting of AET naive patients who were node positive, metastases negative, with a high risk of biochemical recurrence. And these are patients that were also recruited either through the PATCH study or through the previous STAMPEDE trials. What this study was able to show was that there was non-inferiority of metastasis-free survival and overall survival for transdermal estradiol compared to LHRH agonists. The transdermal estradiol was also shown to have, as expected, more breast events with better improved vasomolar outcomes for folks. And moreover, there was an improvement in overall bone health and bone mineral density that was seen in the transdermal estradiol group, as well as no excess cardiovascular toxicity. And so what the authors recommend is that the transdermal estradiol actually be used as first-line ADT. We've obviously, these are not part of the current guidelines as well, but it's something that to consider for folks that may have different needs or quality of life factors. There is much more familiarity with LHRH agonists and antagonists in the treatment of precocious puberty in gender-affirming hormone therapy, as well as in ADT in advanced prostate cancer. So just as a review, our agonists include leuprolide, goserelin, and triptyline. These agonists are associated with an early LHRH surge that are often used alongside the first generation non-steroidal anti-androgen therapies, such as bifutamide. More recently, LHRH antagonists were developed, and those include degarelix and the new oral Urologic. Well, I'll briefly mention the second generation non-steroidal anti-androgens here, so enzalutamide, apalutamide, darolutamide that have been discussed in the past. I won't go into their details, nor about the CYP17A inhibitor, so ketoconazole and abiraterone. The use of both agonist and antagonist therapy has been felt to have different outcomes, specifically with regards to cardiovascular events. In animal models, there was an early report around the use of agonist therapies that could possibly induce plaque rupture and instability more to a greater degree than the treatment with antagonists in these mouse models. We do have a lot of meta-analyses that have looked at large trials, and the results are mixed in terms of the effects of antagonists versus agonists. So in three meta-analysis studies, they're finding that antagonists decrease cardiovascular events in individuals, mostly in individuals that had pre-existing cardiovascular disease. Whereas the other studies found no difference in the use of antagonists or agonists for an increased risk of cardiovascular events. There was one clinical trial that was supposed to sort of answer this question, with the primary outcome being major adverse cardiac events. So that was the PRONOUNCE trial in 2021 that was reported. The main outcome for this one showed no difference between the agonist and antagonist therapy. However, there's also some criticism for this trial, given that there was incomplete accrual, just over 50%, and low power to really determine that statistical significance. As mentioned prior, there's also a new oral LHRH antagonist that's Regularix that's being rolled out for androgen deprivation therapy. I don't believe this is available yet in BC. What they were able to show was that there is sustained testosterone depletion within an average of about 4 days, as well as sustained activity with a quicker reversal effect for individuals on intermittent therapy within the 90-day treatment. I'll briefly touch on intermittent therapy because I think it's important given the history that we have here as well. So there was already a grand rounds on intermittent therapy given a few years ago, so I won't go into some more of the details of it, but intermittent therapy may benefit select patients that have very bothersome side effects, and we do have RCTs to support its use. I think the main thing I want to highlight is that the preclinical trials that were done in animal studies for the use of IADT were performed here at UBC, mainly under the work by Dr. Gleave, Dr. Goldenberg, and Dr. Sullivan as well, who provided notably the scientific context for the early practice of intermittent ADT. We had a Canadian trial, the PR7 trial, which was able to report non-inferiority of intermittent ADT compared to continuous ADT for overall survival in patients with biochemical recurrence after radiation therapy. In the US, the SWOG 9346 trial was a negative trial to determine non-inferiority for survival outcomes, but did show good quality of life benefits for individuals who are on intermittent ADT. So I think this is an important part to sort of move into as talking about quality of life and the impact on quality of life metrics, because I think this largely stems from the social implications of ADT and how androgens alter the function and well-being of individuals. So qualitative data from cisgender heterosexual men who stop or refuse ADT in the setting of prostate cancer do so with feelings of emasculation or fears of feminization in appearance or in personality. This is somewhat of a largely social construct that their male gender is determined only by hormones, and a myth that their manhood depends on testosterone. I think this is a more complex understanding of gender and identity, whereas this social construct around the male gender can be felt or be lost in this population rather than from their lifetime of living as cisgender men. And it's quite an interesting notion. Moreover, the experience of either spousal or relationship breakdowns in heterosexual and heterotypical couples while on ADT, it's been reported or qualitatively as largely due to loss of libido, erectile dysfunction, as well as physical withdrawal from intimacy. This has also been reported as a difficulty in sort of fulfilling the heteronormative male gender role of being a sexual being, and that's lost. 95% of prostate cancer survivors experience some sort of sexual dysfunction, and about 50% of them find that these are moderate to severe impacts on their quality of life. These men on ADT often feel that they need to hide their emasculated state because of these quality of life impacts, sort of in the same way that the eunuch population hides theirs, more to different ideas of stigma. So finally, we have our CUA guidelines that offer us some important information and considerations for individuals with chemical or surgical castration status. So with regards to cardiac health, ADT may increase the risk of cardiac complications, as we mentioned before, especially in patients with pre-existing cardiovascular disease. So as recommended, there should be routine monitoring and referral to a cardiologist or cardio-oncologist for the optimization, which is recommended. In terms of VTE and PEs, as well as stroke risks, individuals on ADT are at an increased risk, but the data doesn't really support the use of routine prophylaxis for this. As well, ADT increases the risk of developing metabolic syndrome and should be included in the screening and medical optimization, such as blood pressure control, fasting glucose monitoring, and hemoglobin A1C, as well as fasting lipids and maintenance of body weight, either through an exercise program or through weight training. With regards to ADT and bone health, bone mineral density loss and osteoporosis increase the risk for fractures, especially within the first years of treatment or castration. The recommendations include a baseline DEXA scan for all patients that start ADT, as well as supplementation with calcium and vitamin D to treat the early symptoms of bone loss. And for those with osteoporosis that are determined by DEXA scanning, they can be started on either bisphosphonate therapy or denosumab by our endocrinology colleagues. So this is a nice summary table, just of the recommendations that are included here. So for cardiovascular risks, the lifestyle modifications also include smoking cessation, exercise program, and dietary modifications, with hypertension monitoring and targets for less than a 130 over 80, as well as screening for diabetes and hyperlipidemia every 6 to 12 months. The pharmacotherapies that can be used as adjuncts are usually statins, aspirin, and ACE inhibitors. In terms of bone health, there on the right, it's important to identify individuals that are at risk at fall or limited mobility, as well as to counsel around alcohol and smoking cessation, which can further decrease bone health. For individuals that are starting on ADT, a baseline serum calcium and vitamin D level would also be warranted, as well as adequate calcium supplementation. So at least 1,200 milligrams daily orally for calcium, and for vitamin D, 800 to 1,200 international units daily. The screen for osteoporosis is usually done at baseline, and then either on a 1 to 2 year basis for those with osteoporosis, or every 3 years for those without a significant fracture risk. Some of the other quality of life metrics that are used are bothersome vasomotor symptoms. And so for this, what can be considered are estrogens and progestins, as well as the use of anti-androgens or any other identified agents. So in the guidelines, it includes gabapentin and venlafaxine. Something that is often trialed for vasomotor symptoms is a consideration of androgen deprivation therapy for individuals that undergo castration for non-surgical or oncological reasons. Possibly the return of either testosterone or estradiol can be discussed. For bothersome breast events, usually the treatment is tamoxifen, which is preferred, or it can also be low-dose radiation therapy to the chest. For some individuals and select patients, the surgical management for gynecomastia can also be recommended. And finally, for sexual functioning, as this largely affects the quality of life of individuals, appropriate pre-treatment counseling, including changes to the penile or testicular size, is warranted for individuals on androgen deprivation therapy. The main sort of stay of supportive therapy can be sex therapy or the use of PDE5 inhibitors or ICI injections as well. And for this, the use of intermittent IADT can be discussed. So this brings me to the end of my talk today. And so hopefully what I've conveyed is some of the social significance and the physiological roles of androgens, with a highlight on those broad social and identity phenomenon that has evolved to see both within the patients that we have that are being treated for adenocarcinoma, the prostate, or within our eunuch population, as well as how we see and treat those that have androgens and those without. So I want to thank everyone for their time, and I'm happy to take questions or hear any comments.